So this very easily could have been a mass casualty incident. We are so lucky that it wasn't. Joining us now, though, is Dr. Ali Raja, Vice Chair of Emergency Medicine at Mass General Brigham. And we've spoken on this topic. Unfortunate that we've had to before, Dr. Raja. But you are prepared in the ED for something like this.
We are, Erica, and it's really unfortunate. When we get the heads up from the EMS crew or from police that a patient with a gunshot wound's coming in, we mobilize really fast. So as soon as we hear that a patient's on the way, we activate the trauma team, we alert the blood bank, we get everybody ready so that we're ready when they get to us.
And Dr. Raja, can you tell us this afternoon, was this alerted as a potential mass casualty event? And what does that entail inside your ER?
Yeah, it's a great question. It wasn't alerted as a potential mass casualty event, but we knew about the gunshot wound, and we're always ready for a mass casualty event, especially when there's multiple gunshots like this. What that means is getting prepared even before the first patient gets there. Anybody who's watched an episode of The Pit has seen this. We get the trauma bay or trauma bays ready. We assign doctors and nurses to each of them, making sure that no matter how many patients we get, we're ready for any number of patients, and we turn those rooms over as quickly as we can, because sometimes we don't know whether we're getting one patient or we're getting a dozen patients.
So, Dr. Raja, talk about some of the advancements in treating gunshot wounds that we've seen for better or worse, I guess, over the last 25 years, because of a lot of the work that you folks in big U.S. cities are doing.
That's a great question, Ben. A lot of it, while we get to use it in big U.S. cities, I've got to tell you, actually comes from the battlefield. Tourniquets were first used there, and now we use them every time we have serious arterial bleeding in a patient, even in a major urban city. We have gotten away from necessarily treating the airway or breathing first, and instead focusing on what we call exsanguination or major bleeding. If somebody's coming in and bleeding, sort of reordering the way that we treat patients. We have changed the medications. There's medications that we trialed out in the battlefield that we now give in trauma patients in the city. And we've also got some really advanced and cool stuff. There's foams that we can use to treat patients bleeding inside their bodies and temporize it until we can get up to the operating room and definitively treat them up there.
What strikes me in listening to you, hearing that we've learned these lessons from the battlefield, is that unfortunately this is a city street and we shouldn't have to use those kinds of techniques. But obviously we appreciate all the work you do. Is this something that you have to train for regularly? How does that work?
It's a great question, Erica. Yes, we do train for it regularly, but unfortunately, it's also the kind of thing that we train by doing, because it's not an uncommon occurrence. You're absolutely right. It's something that we shouldn't have to see on our urban city streets or really anywhere in the U.S., but we do see it regularly. And so we have a very specific training plan. Everybody's got a role assigned. There's nobody who's unsure of what they're going to do as soon as that patient rolls in, whether it's managing their airway or doing procedures to stop the bleeding, or even we have a dedicated nurse whose job it is to record everything that's going on so that we can review it afterwards to see exactly what went well, which is what happens most of the time, or what didn't if something happens badly.
All right. Our thanks to Dr. Ali Raja for the work you do every day and for lending us your expertise. We appreciate it, Dr. Raja.
Thanks, Ben. Thanks, Erica.